call upon stage Dr. Amit Porwal. He will be talking about combined surgery, cataract plus trab.
There's a change in the sequence. Myself, Devin, and Ganesh, we have a parallel IC running out now. We have to go there. So Trupti will be moderating the whole session, and I'm going to talk on combined surgery, cataract plus trab. No financial disclosure. So combined surgery is also known as a triple procedure. What are the indications basically for this procedure? Patients with cataract and glaucoma. These patients who have failed to achieve target pressure by medication. So the indications is patients who are having cataract with glaucoma in which they failure to achieve target pressure by medications. There are issues related to compliance, adherence, and drug-induced side effects. They are borderline controlled IOP, disease progression, or advanced GOA despite maximum medical therapy. And even when you have uncontrolled glaucoma but an urgent need to restore vision, or when two operations are not feasible. The advantages of combined procedure, we all know about it. It eliminates the need for two separate surgeries, it reduces the cost, it reduces the early post-operative IOP rise significantly. The significant improvement in the visual acuity and IOP, and is also decrease in the number of anti-glaucoma medications post-operatively. Coming to the technique, you have the single site and the twin site technique. Single site technique can be done through SICS trap or a phaco trap on the same site. Twin site is basically you do a trap superiorly and do a cataract surgery temporally. I would always advise a phaco trap to be done in twin site and never an SICS trap, because the amount of congenital dissection is too high. So we advise only phaco trap in a twin site surgery. Now coming to the two videos, I will be showing simultaneously both the videos. So after taking the superior rectus stay suture or a corneal stay suture, you always mark a congenital flap. If it's an SICS trap, I will mark it at 6.5 mm, and if it's a phaco trap, I mark it at 3.5 to 4 mm. Congenital flap is created in one go, and it is dissected subcontinentally as much posteriorly as possible so as to have a diffuse posterior flap. Identify the bleeder and cauterize only the bleeder. Never over cauterize the bleeder, because if you over cauterize the bleeder, then when you prepare the scleral flap, there will be shrinkage of the scleral flap. Again, if you want to put any antimetabolite, what I do is before I make the scleral flap, I place the antimetabolite. The concentration and the duration of exposure depends on individual case-to-case basis. And now what I do is I give some subcutaneous injection of mitomycin before I start the procedure. So making the scleral flap is a very, you have to be very careful. You just lift the apex of this triangular flap, which I usually do a triangular flap. So just lift the apex of the triangular flap, pull it as much as possible in the air, and just touch the cutting edge of the 15 number blade at the junction. So you will get a uniform triangular flap. Again, as I said, as you mark the congenital flap, also make sure that you mark the scleral flap also. So once the scleral flap is made, then the procedure of cataract surgery remains the same, what you have been used to, whether it is SICS or phaco. So in SICS, the two lateral horns, and then the entry, the side foot, all the steps remain the same. In phaco, once you have made the scleral flap, you shift temporally, and then if it's a twin site procedure, you can do a single site also. In a twin site procedure, shift temporally and then start your phaco procedure. Only thing which we keep in mind as a glaucoma surgeon, when we are doing this combined procedure, we should be preoperatively prepared to see the amount of pupillary dilatation which is expected when you put the patient for surgery. So you should always document it preoperatively when you examine the patient. What is the pupillary maximum size of the dilated pupil, whether it is 6 mm, 5 mm, 4 mm. So we should be prepared mentally to tackle these small pupil issues also. So in this case, I was using a Malyovian ring. This was a case of complicated cataract with secondary glaucoma. So in this Malyovian ring was planned. So you can plan any pupil expansion device which you want. Again, the recommended technique is a slow motion phaco, which I recommend because I don't want a lot of pigment dispersion. I don't want a lot of turbulence into the anterior chamber. And you can use whatever preferred choice of your phaco technique, whether it's a direct chop, stop and chop, divide, whatever you are comfortable with. So tackling the cataract part remains the same. Only modification is the steps of the surgery. Basically in twin side, you move temporally. In the superior side, once you create the flap, then you have to proceed with the cataract surgery. Again, when you inject the IOL, you make sure that the IOL is into the capsular bag and place the IOL haptic at 3 and 9 o'clock. You should never place the IOL in the sulcus. If the dire consequences, I mean basically if an emergency arises when the support is not good, then you can place it, but otherwise avoid it placing the capsular bag, because quite a few times we have seen the haptic coming out through the broad-based peripheral iridotomy which is done, and it is disturbing the cornea or the angle. Again, internal ostium preparation, I missed that part. Telling you all, internal ostium can be created with the help of a 11 number blade or it can be created with the help of a vanas, or it can be held with a Kelly sponge or an MVR. I'll show you the videos of how to create this internal ostium with various instruments. So once the internal ostium is created and a board-based peripheral iridotomy is done, suturing is very, very important. What I used to do is a single intermittent apical suture of 10-0 ethicon, and I used to put 2 releasable suture. So releasable suture is very important. Everybody should learn how to put the releasable suture. My technique, what I've learned is basically pass this suture into the clear cornea parallel to the limbus in front in the clear cornea, then from the clear cornea perpendicular into the scleral flap, and then from the scleral flap into the intact sclera. A loop is created over the scleral flap. Take 4 throws and pass these throws over this loop. So it's like a shoelace pattern knot which is there. Similarly, I'm doing this on the other side. So the suture is passed into the clear cornea in front of the limbus, and then the sutures are tightened in. Releasable suture gives us a better control. You have a tight AC, and post-operatively you can release this releasable suture to titrate the amount of IOP reduction what you want. Conjunctival suturing is very, very important. You should always remember to take an anchoring bite at the limbus or the episcleral bite. Take interlocking sutures with 8-0 vicryl. Why you should take the anchoring suture is because of the upper lid movement. You don't want the bleb to be retracted posteriorly. So you want the bleb to remain there only, so that you have a posterior diffuse bleb. For this, you need to take the episcleral bite in the episcleral tissue or in the limbal tissue. So interlocking sutures are done. Once you have tightened on the right side, the left side, make the canthal flap taut and put the suture similarly. This tautness has to be there, because if this tautness is not there, there will be leak, and then you have to put a matrix suture between these two conjunctival sutures what you have put, so that the leakage is not there anteriorly. By doing this, following this technique, basically you will get a posterior diffuse bleb. Hydrate the AC, reform the AC, and whatever exposed part of the residual sutures are there, you just rip it off and hydrate and see that the adequate flow is there, and you get the posterior diffuse bleb. So another clipping which I wanted to show was to make the internal ostium. There are two clippings which are showing simultaneously. So you can see in one Kelly sponge is used. Kelly sponge, you can make an L-shaped opening or a mushroom shaped opening, whichever you are comfortable with. With our MVR at the blue-white junction, just make a stab incision, extend a bit, and then with the help of vanas, cut the 2 thorns, and then you get the internal ostium is prepared, and then you do a broad-based iridotomy. So again, variations in the techniques are there. This is a normal SICS straight tunnel. Just make sure that you place it 2.5 to 3 mm posteriorly, and you can continue with this. Again, here also you can put 1 intermittent and 1 releasable suture, or you can do this with the MVR also, the preparation of the internal ostium. So there are slight variation in the technique. Everybody has their own modifications. So these are a few modifications which I wanted to tell you about. So thank you. I think we'll take the next speaker, Ganesh. Part of the residual sutures are there. You just rip it off and hydrate and see that the adequate flow is there, and you get the posterior diffuse bleb. So another clipping which I wanted to show was to make the internal ostium. There are two clippings which are showing simultaneously. So you can see in one Kelly sponge is used. Kelly sponge, you can make an L-shaped opening or a mushroom shaped opening, whichever you are comfortable with. With our MVR at the blue-white junction, just make a stab incision, extend a bit, and then with the help of vanas, cut the 2 thorns, and then you get the internal ostium is prepared, and then you do a broad-based iridotomy. So again, variations in the techniques are there. This is a normal SICS straight tunnel. Just make sure that you place it 2.5 to 3 mm posteriorly, and you can continue with this. Again, here also you can put 1 intermittent and 1 releasable suture, or you can do this with the MVR also, the preparation of the internal ostium. So there are slight variation in the technique. Everybody has their own modifications. So these are a few modifications which I wanted to tell you about.